Hello, everyone, and welcome to this next episode of the Akkad and Koka Report. I'm Michel Akkad in San Francisco, and with me is my co-host, Dr. Anish Koka in Philadelphia. Our topic today is Hippocrates, and I think it would be fair to say that for most doctors, Hippocrates is a quaint figure of the past with hardly any relevance to the modern practice of medicine. We may know him as the father of medicine, but we have no idea what really connects us to him. We may occasionally and sanctimoniously proclaim, "First do no harm," but we ignore the origin and significance of that phrase. Some of us may have taken some modified version of the oath of Hippocrates upon graduating from medical school, but few of us think of it as a serious pledge with any real consequence for our day-to-day practice. And over the last decades, most bioethicists have deliberately set aside the Hippocratic tradition, deeming it inadequate to help us deal with the moral quandaries that arise in the age of scientific medicine. So, is there any reason besides historical curiosity to become familiar with Hippocrates, let alone take him seriously? To help us sort this out, we have a distinguished guest who is the author of a brand new book entitled Hippocrates' Oath and Asclepius' Wound, The Birth of the Medical Profession, published by Oxford University Press. Thomas Cavanaugh is professor of philosophy at the University of San Francisco, where he teaches medical ethics. He is the recipient of a grant from the National Endowment for the Humanities, and his previous book, also published by OUP, is entitled Double Effect Reasoning, Doing Good and Avoiding Evil. As always, you will find all the needed links on the show notes at akkadandkoka.com. Tom Cavanaugh, welcome to the show.
Thank you for having me. Thank you. It's a pleasure to be here.
We're delighted to have you. So, Tom, let's dive into the topic of your book. Here we are in 2018. We have modern biological knowledge, genetics, randomized controlled trials, artificial intelligence, machine learning. Do we need Hippocrates? What's the relevance?
Well, we all intuitively regard medicine as a profession. It's probably a paradigmatic profession. So if you ask someone, give me an example of a profession, I think most people would quickly hit upon medicine and being a physician as an example, perhaps the principal example of being a professional, a member of a profession. And if we look at that, word profession, it's a Latin word and it has a history. And its original meaning in Latin, pro means before, and the fashion part comes from the Latin fatere, which means to speak before. So originally in the first century BC Rome, we had professio. People would make professios to tax authorities, and they would say what they were. They would say, "I am a," and then they would say a doctor, or "I am a tradesman," or something. So, but very quickly in the Latin, in the Roman ages, the concept acquired, especially with respect to medicine, an ethical commitment. So professio quickly became a word to describe an art that included an ethical commitment. So there were certain arts, techniques, certain things like, say, plumbing, that doesn't include any ethical commitment. It's just a technique. It could be used to make water run in a sanitary fashion, or it could be used to make water run in an unsanitary fashion, and it would still be plumbing. And the plumber would not be violating his practice. Whereas it was understood that being a physician it incorporates an ethic, and therefore it's not merely a technique. It's oriented towards certain ends and certain goals, and it is opposed to using this technique for certain ends. So it will use them for certain purposes and not for other purposes. And if we want to understand where we get this concept from, it's not really so much from the Romans, but rather from the ancient Greeks. And the ancient Greek that looms largest is Hippocrates and the oath that he left us. So Roman physicians will say that Hippocrates was the founder of our profession. And when they use that word, what they're referring to is the oath. He founded not the technique. He inherited the technique. And he probably also inherited the ethic that he gives to us. But what he definitively did was he defined medicine as incorporating an ethic internal to itself so that the physician will use this art for the benefit of the patient and will not use this art to harm the patient. And that makes medicine a profession, whereas if we don't have that commitment, all we have is a technique. And Hippocrates was well aware of a view of medicine in which it was only a technique. So if we look at the mythologies from Apollo, the god of medicine, and Asclepius, the demigod of medicine, to whom Hippocrates, before whom he takes the oath as witness, they would use the technique either to heal or to sicken deliberately. They would deliberately use the technique either to cure a person or to spread plague. And Hippocrates was well aware, based on the Greek mythology, and also based in Greek tragedy and the story of Telephus, which I mentioned in the book and which is on the cover of the book. This is if I could just put...
Yeah. Show it for people on podcast. They may not see it, yeah. but the cover of the book is. Go ahead, describe it for us.
This cover of the book is a marble sculpture that was found in Herculaneum, which was buried when Vesuvius erupted in 79 A.D. And it's called. This is a very famous story being depicted in this sculpture called the Relief of Telephus. Excuse me, the healing of Telephus, not the relief, pardon me, I misspoke. The healing of Telephus. And this is Achilles. You can see this man here. He has two very sharp instruments in the abdomen of this gentleman here. This is Telephus, this is Achilles. And Telephus is being healed by Achilles, who had previously wounded him. And Telephus was told by the Delphic oracle. What happened was in the Greek stories, we're told that when Achilles went to attack Troy, he first attacked Telephus's city by accident, by mistake. Telephus successfully defended his city, but he was wounded by Achilles. And so the wound would not heal. And even to this day, we could call a wound that does not heal Telephion after this Greek story. Telephus went to the Delphic oracle and said, "What am I to do?" And the Delphic oracle at Delphi, that would be the Apollo, the priestess of Apollo, the god of healing. She told him, "The wounder heals. The wounder heals." So very paradoxical. The Greeks love paradox. So the wounder heals. So eventually, he goes to Achilles, who's not a doctor, and he says, would you heal me? And Achilles does heal him by scraping little filings from his spear, which originally wounded Telephus, into Telephus's wound, and that heals Telephus's wound. Now, the relevance for our purposes is this: the wounder heals. That was an aphorism for the Greeks. It was part of their culture. They had these aphorisms like "know thyself," everything in moderation, things like that.
Right.
Well, this was one of their aphorisms. The wounder heals. And it was the story of Telephus was dramatized by the three great Greek tragedians, Sophocles, Aeschylus, and Euripides. All wrote dramas about the story of Telephus. So the ancient Greeks were intimately familiar with this story. It was like almost biblical, if you will. When our culture was very familiar with the Bible, it would have been similar to that. The point being, if the wounder heals, it's also true that the healer wounds. And what Hippocrates is, he's very familiar with this, and he's trying to prevent the healer from wounding. And the way to do that is to have an oath, so that healers, as I note, sometimes there are wounds that are ineliminable from medicine, like cutting and incisions and cauterizing. But what Hippocrates is trying to eliminate from medicine is deliberate wounding, where the healer actually is setting out to wound.
Right. So, in your book, you make that point. You delve a little bit into this question of wounding, and you come up with 3 categories of wounds.
Yes.
So go ahead and tell us a little bit, because I think that's critical. That ends up being the sort of the thread throughout the book.
Yes. Yes. So
the recognizing this reality about wounds inflicted by healers or doctors.
Yes. So there's a very gross categorization of wounding that I employ, but I think it captures important distinctions. And the first type of wounding I mentioned just now, which is ineliminable from excellent therapeutic practice and excellent clinical practice, would be what I would call wounds of therapy. These are wounds like cauterizing, cutting, injecting. Also, as you know, any kind of drug always has some associated unpleasant side effects. It could be nauseate a patient or something like that. Those are what I would call wounds of therapy. I think ever since I've been going to doctors, at some point in my interaction with doctors, there's something like a statement like, "This is going to hurt,"
right?
Being injected or something like that, and that is ineliminable from the practice of medicine. Even excellent medicine. Medicine will try to make those wounds smaller, will try to make them heal more quickly, try to make them less painful, but they're not going to be eliminated from even excellent medical practice. And that's just because the dis-ease is always in a larger organism that is not diseased. So we're trying to treat that in the patient, and we always affect the patient otherwise. So that's the first category of wounds, those wounds of therapy that are not going to be eliminated from the practice of medicine. Now, another broad category are errors or iatrogenic diseases, where iatros is a Greek word, means physician, genic means born of or caused by. So iatrogenic disease, of course, we want to avoid those, and they are avoidable. They are mistakes. Things have gone wrong. Someone made an error. Someone walked off the correct path. But those will also be part of medicine, because medicine always involves, it's empirical, it's experiential. We can even learn what kind of mistakes we can make as one practices medicine. So those are going to attend medicine, even though they are eliminable. I mean, to err means you
right.
walk.
I mean, humans are fallible. I mean, medicine is practiced by human beings, and
correct. Exactly. Right. That's the idea. Now, the third. So we have errors. The third category is what I call role conflation. This is, for lack of a better term, really, I call it role conflation. And this is what Hippocrates is trying to eliminate from the practice of medicine by the oath. And role conflation is when the physician sets out to wound deliberately on purpose. Now, of course, people are going to debate what is a wound and what is not a wound, what is health and what is disease. But one of the examples that I give from history is from Dr. Guillotine. Dr. Guillotine and his colleague, Dr. Luis, who was a surgeon, they wanted to minimize, ameliorate, lessen the grisliness of capital punishment. And so Dr. Guillotine, with Dr. Luis, Luis really developed it. Guillotine kind of came up with the idea of doing.
And that's at the time of the French Revolution.
Yes, correct.
Right? Yeah.
Yes, okay. The capital punishment, to make capital punishment less distressing for the person who was put to death. Dr. Guillotine was motivated by humanitarian concerns and egalitarian concerns. But I think, in keeping with Hippocrates, he really is erring because he's adopting the role of a wounder. And that's a deliberate wounding when we're going to take a person's life by the death penalty, by the guillotine. That's a deliberate wounding. I'm not arguing for or against the death penalty. I'm talking about a physician being involved in administering the death penalty. That's role conflation. The physician now has adopted the role of a punisher, and that's not in keeping with the exclusively therapeutic role that is appropriate to the medical profession. So those are the three types of wounds. And
right. So let's explore this a little bit. So you have the physician wounding deliberately, but in the case of the guillotine, it would be perhaps to achieve a lesser.
Yes,
less
harm
painful,
reduction.
harm reduction, right? But nevertheless, so it's an act of harm, but it's less than what it would be otherwise.
Correct.
Right. So it's involving the art of medicine to inflict some harm, and then there's another kind of harm reduction, or where actually the wound itself may be even misinterpreted as a good or as better, or I think you make a distinction between sort of two different kinds of deliberate wounding.
Yes, there could be a debate. So there's kind of Apollonian, what I distinguish between, I call the Apollonian and the Asclepion view of medicine, both of which regard medicine as compatible with killing. And the I rely a little bit on the notion that's a use of terms that I'm introducing.
Right. Rely on some
for my mythology to some extent. So Apollo is a god, and so the notion is that God would have more authority over life and of death. So the god could use the technique outright to kill, regarding killing as a bad thing. Right. An Apollonian physician, if you will, would view it as purely a technique, would acknowledge that killing is a bad thing, and would just say, sometimes I just use my technique to kill.
Right.
I'm not trying to say that killing is a good thing. Now, the Asclepion, because he's a demigod, he doesn't make these claims that gods will make. He says something like, well, killing is not harmful. It's not harmful. And so there's a quarrel I would have, and I think Hippocrates would have with that individual, concerning that is killing actually therapeutic. And I try to argue that it's not. And I believe that guillotine, he's hard to place. I think there's an element of an Apollonian character, or you could say maybe he's non-Apollonian, but he's not saying that killing is good. He's trying to say, well, we're trying to minimize the badness of it. But at the end of the day, he's still punishing, and it might be less of a punishment than the alternative, but it is. But one wonders if that's appropriate for a medical professional to be involved in an act that actually is one of inflicting a pain. That's poina, is pain and punishment. We can't escape that aspect.
I think I'd like to get back to, the questions that are now to us, to most doctors, are a little bit peripheral.
Yes.
The question of the doctor's involvement in capital punishment. And
sure.
So forth. I think
yes.
If we have a chance, we'll get back to that at the end. But here, one thing that comes to mind when I was reading your book, and you don't mention it very explicitly, but in a way that we could be practicing a type of Apollonian medicine nowadays, is when we employ certain treatments on a large, essentially the application of utilitarian principles, where the doctor will be asked to do things on a large scale, thinking that it's going to benefit the masses at large, even though there may be some people that who get harmed.
Yes.
And that would be sort of an accepted way of practicing today. So it's a little bit different than the Apollonian because the harm may not be intended.
Yes, correct.
But nevertheless, it's sort of accepted that
Mm-hmm.
it's the price to pay,
Mm-hmm.
and that even though it may not benefit the patient directly, it's a price. One example would be that doctors are being pushed to practice. For example, you're a primary care physician. You have a panel of patients. 3,000 patients, whatever, and you're going to be paid, by the insurance company or the government, according to what the average cholesterol level in your patients is.
Yes.
So there's an incentive to reduce the cholesterol in everybody.
Yes.
And that sort of thing. And because it's good for the population, it's good for the group, and so forth. Even if individually, perhaps it might, you're going to be not thinking about the individual benefits or the healing process to one person. Vaccination would be another version of that reasoning. But what do you think about that? I mean, is that a way of, it's a departure from the traditional Hippocratic?
Well, I think there it's the unit of treatment. The unit, what is the subject of the practice? What is the subject of the practice? So, certainly the Hippocratic approach, the subject of the practice is the individual patient.
Right.
Now, does that mean that it's inappropriate ever to regard a larger unit, say an actual population? It seems like, as you're saying, like, for example, vaccinations. There, we might be thinking perhaps appropriately that the subject is certainly the individual patient, but also there's a larger unit there that's being treated as well, which is a population of people. So I think I don't know that, as you said at the beginning of your comments, it probably is more utilitarian than it is Apollonian, and it can be. I think we wouldn't want medicine to become only a practice in which we're treating populations and we're no longer treating individual patients. That seems to me that would be a dramatic departure from what all of us hope to encounter in the clinical interaction. But at the same time, there may be instances where it's appropriate for the physician to have, in addition to the individual patient, the population as well. I think that we would always have the individual patient, the welfare of the individual patient is always probably the standard or the norm that governs the attempt to benefit the wider population. So maybe it's a limit, as it were, on the goal, the more social goal, the larger goal to treat the population.
I guess where I find physicians run into problems is when we attempt to generalize too much. Meaning, whether it be current times where we are defining groups based on large trials, evidence-based medicine, or whether it be prior times where it was the experience of the physician that said, all right, this overweight physician who eats too much sweet, it's bad for you. And, you say, based on your experience, that you need to eat less. I mean, any advice that you give the individual is in some way based on their belonging to a certain group, correct? That's how physicians since forever have tried to give advice to the individual sitting in front of them. Where I think we are starting to run aground is when we stop thinking and start generalizing entirely too much. So, when you have data that's generated on, say, a group that's X, and then when a patient comes to you because you're because you're implementing some guideline, it kind of behooves us to make sure that the individual that's sitting in front of us really does belong to whatever group it is that you're then practicing based on. What I find over and over again these days is that physicians have become more robot-like in that we're so in love with simple heuristics that, you know, if, an inpatient who's in the hospital, if a certain number is up, that automatically triggers some early warning system. And based on that early warning system, a nurse then protocolizes and triggers some alert. And based on that alert, automatically some therapy happens. And that is a physician not discharging his responsibility to the patient. Because, you know, on all this, the physician may barely see the patient. All of this is being done without there being an actual relationship between the patient and the physician. Meaning, a lot of this stuff is happening in hospitals with the person on the ground who would have traditionally seen the patient, gone through the patient's individual, you know, what's going on, what's his creatinine, what's the urine output, what's the blood pressure, what's the context of this, of whatever presentation is going on, and then make a decision, right? That's what should be happening. But instead what's happening is, because we're so in love with trying to protocolize things, we're moving the patient, the physician further and further away from the patient. So as soon as a heart rate above 100 is detected and there's a temperature over 100.0 detected, that's two out of 4 criteria, and a protocol is automatically initiated where a nurse checks a lactate level. If the lactate level is over 2, automatically the nurse is now calling the physician who's on call and saying, "Hey, this is, you know, the Muse early warning system has been activated. It says we should give fluid. Or is that okay?" And guess what happens? They say, "Okay, give fluid." Now, then it turns out the patient has heart failure and can't get all this fluid, and the next call you get is the patient is hypoxic, and you know, now some other protocol is being triggered. So
yeah, I agree with you, Anish, completely, and it speaks to you know, a point that you make repeatedly, Tom, in your book is, I mean, right now the emphasis is on the technique. From, you know, the technique seems to have taken precedence, as if the technique immediately tells us, and not just the technique of what we do, but also the information that we get from the patient has taken on sort of a technical character. Meaning we don't look at patients necessarily as complete, you know, wholes or individuals, but we take there are certain features that we, you know, I was using the term of, you know, the example of the cholesterol level or the this or that. Anish is, you know, the vital signs in the hospital. So these are sort of data points. So we're the focus on the data points, right?
Yes.
And this entire focus on data points of practicing medicine just on the basis of data points is very, very highly technical. And there's a sense that, you know, doing this is what really medicine is about.
Right.
And that's, you know, we've lost. But at the same time, we are, you know, still the goal, at least allegedly the goal, even if we're super technical, the goal is still to wound, even if we, you know, we do it badly. In fact,
or
we
to
commit
heal.
To heal. I'm sorry, to heal, exactly.
Right.
To heal, even if we do it badly, we end up
certainly.
making errors, and there's all kinds of mischief that. But there's still, I mean, there's a change of, I mean, the focus has been on the technique much more so, in my mind. I mean, part of the problem, as you know, the example that Anish gives, is that the focus has been really on, you know, these technical prowesses, and also understanding a certain understanding of the patient that is primarily that the patient is a sum total of data points.
Yes.
Right? Which doesn't really, in my mind, do justice. And in a way, the concept of healing, I mean, if the doctor is going to heal, which is, and follow the Hippocrates prescription, if you will, to only heal, and his proscription, you know, against wounding, health, the idea of health really pertains to wholes, right? It cannot pertain to a collection of data points. So you have to have a certain understanding of what the whole human being is, the whole person is. And so we don't have that. I think we're committing a lot of errors, even if we're still, you know, aiming to heal.
You know, that is a societal problem. It's not only in medicine.
I agree. Yes,
it is that we have great difficulty in our culture thinking of the relationship between whole and apart, especially we're very good at breaking things down into their parts, but we're not very good at seeing how parts work as a member of a whole. And that includes, for example, I mean, we're very individualistic society. So we think of each one of ourselves as a whole. And then, but it's very difficult for us to think of ourselves as parts in a larger whole, that is, as members of, say, a society. And the whole issue of the common good. We're very good at understanding the private good, my individual good. We have a lot of difficulty understanding how my individual good relates to the good of the whole community. And I think that, I mean, that's just an instance of this difficulty being found in medicine, where it may be for the breaking things down into their parts. An example that comes to my mind, I only mention it because it may be common amongst the audience, or I don't know if you've ever seen the movie My Dinner with Andre.
I have, yeah, a long time ago, right?
Yeah, so it's been a while. But in that movie, which I recommend, it's a lovely movie, one of the characters is speaking about his elderly mother who broke her arm. She broke her wrist, I believe. And and he says how the orthopedic surgeon who did a wonderful job in setting his mother's wrist came in to see his mom and said, everything is fine. It's just perfect. And of course, his mother was dying. She was dying. Now, the orthopedic surgeon, he was talking about the hand, and it was perfect, as the character in the film acknowledges. But he said the difficulty was that his mother was dying with a hand that had been repaired just in a most wonderful fashion, and that the orthopedic surgeon didn't see the hole. Now, that's not a criticism of orthopedic surgeons. It's more acknowledging that we're very good at seeing the small little part, but we don't always see how it fits into that larger whole. And you mentioned the whole person. In Anish's comments earlier and your comments now, I think that reflects a difficulty that our society has. We're very good at the analysis and breaking things down into their smallest parts. But we as a culture, actually, and this would just be symptomatic of that in medicine, we're not good at seeing how those parts relate to the whole. Let's say in the instance of the orthopedic surgeon, how the hand relates to the whole organism of this individual woman who actually is dying, or this patient in the larger community of patients, as you mentioned earlier, or those data points, right? That how do they fit together into the care of this particular individual person? One of the things I think is there's a wonderful article. It's one of the first articles written. I think it was in the first issue of the Hastings Center Report, or I can't remember. It was written by Alistair McIntyre and Samuel Gorovitz, and it was on medical error. This goes back into the dawn of contemporary bioethics, like 1968 or 71 or something like that. And it was on medical error, and what they said was we'll never get rid of medical error because medicine is always empirical. It's always dealing with the specific individual in front of the physician. That's a new, unique interaction. We might have a large induction that we've done over thousands and thousands of patients. And yet in front of us, the physician has an individual who has not undergone that phenomenon. And so that specific, the individuality, the uniqueness of that individual will never be eliminated from the practice of medicine. And that's why medicine is truly, it's empirical. It's experiential.
Right. Very good point. But let's go back and dive a little deeper into again the main thrust here, distinguishing, if you will, the Apollonian Asclepion nature of at times wounding and not healing versus the Hippocratic stance to avoid deliberate wounding at all times. So the obvious, and you deal with it at length in your book, the obvious relevance today is the role of the physician in assisted suicide or assisted dying or whatever terminology you want to examine. So tell us, Bob is, 65. He has terminal cancer. He doesn't have much long to live. He's concerned that he will be suffering quite a bit down the line. He asked Anish to prescribe the appropriate dose of barbiturates. What's wrong with that?
Right. So, with respect to doctors, so my argument is somewhat narrow. But just to talk about physicians here, and physicians being involved in giving a deadly drug, because Hippocrates says, I will not give a deadly drug even if I am asked, nor will I counsel this plan. Right. And so why would he say that as a physician? Well, I think there are numerous reasons. He doesn't give us a reason. He obviously thinks it would involve him in the taking of harmless blood, innocent blood, and he doesn't want to be involved in that. He says that in the oath. But otherwise, he doesn't give us reasons. But if we think about reasons, I think one of the principal reasons that comes to mind is that death is the dissolution of the organism. It's the dissolution of this individual, this patient. It's the end of that patient. That individual no longer exists. And death is the terminus of that life. Now, so to take the life of an organism is not therapeutic. It's not a therapeutic act. And therefore, it's not appropriate for a profession devoted exclusively to therapy to perform that action. So that would be one of the prominent, salient reasons to say that physicians shouldn't be involved in that, simply because death is the dissolution of the patient. We can't care for something or anything really by destroying it. And that's also true of patients as well. So it's just simply not a therapeutic act. And therefore, it shouldn't be engaged in by, even if someone thinks, like, I'm not arguing on behalf of the death penalty we talked about earlier, but someone might think that's a legitimate action to perform. But it's certainly not a legitimate act for a person devoted to therapy to perform. Okay. So, so another reason, I think, is that we want to control, oftentimes, one of the things that the impetus to aid in dying or giving deadly drugs deliberately is wanting to be in control of the time and the manner of one's own death, which is understandable. I can see how that being attractive to people, but it's not a medical problem. It's not really a medical problem. If physicians say, "Well, we'll help you solve that," then they're thereby saying that Hamlet's question, to be or not to be, is really a medical question. Whether 'tis nobler in the mind to suffer the slings and arrows of outrageous fortune, right? That's a medical question, but it's not a medical question. It's an existential question. It is a question. It's an existential question. It's a question that boggles the mind, and it's an appropriate question to ask, but it's not a medical question. And for society to ask doctors, say, hey, we have this existential issue. It's called human mortality. We want you to solve this problem for us, and here's how we envision you solving the problem for us. Give us deadly drugs when we want them. Well, we're medicalizing something that is just not medical. It's just not medical. Right. And also, the other thing, just the one further thing I think that we have inadequately appreciated is that it sends the wrong message to people who think that suicide, if I can use that word, I know that's a contentious word to use concerning the practices of giving deadly drugs, but suicide is too many people in our culture commit suicide. They consider it a solution to difficult problems, and we don't want to send a message to those individuals that one of our most admired professions thinks that killing is a solution to difficult problems, because that's just the wrong message to send to people who need us to let them know that we don't think that killing is a solution to very serious human problems, and that we have other ways of solving those serious human problems. Herbert Hendon, who is the gray eminence of suicide in the United States of America, he's a psychiatrist. He's an emeritus professor of medicine at Harvard Medical School. He's the authority on suicide in America, and he has written about this in his Seduced by Death and then Suicide in America, that having aid in dying and all, where doctors are deliberately giving deadly drugs to patients at their request, it is really pernicious to our attempts to prevent suicide more generally in the wider population. So I think that's it's inadequately acknowledged that we're sending the wrong message to people who are in dire straits.
Right. No, I completely agree with you. I wrote a piece maybe 3 years ago or so about physician-assisted suicide, and I think the subtitle was it's the assisted death of the medical profession, because
profession, right?
Right.
Profession.
So not only do we then change our role as wounder. So you mentioned that death is a dissolution of the individual, and therefore it cannot be health, right? Because
Correct.
health is really whole, right?
Yes,
the whole,
exactly.
So keeping the individual whole. So it's
Yes.
But also on the subject of the technique, as you mentioned, really, I can tell you, I can teach you tomorrow how to assist death. There's really no technique involved in giving an overdose of a barbiturate.
Right.
So there's really absolutely no reason for the doctor to be involved.
Right.
In fact, you're asking the doctor to do the opposite of what he or she has learned in training, because you learn to give the proper dose. Here, the proper dose doesn't exist. It's the maximal dose. It doesn't matter.
Paracelsus, who's a great pharmacist, he said, everything is all potions are poison.
The dose is
it's
the
the
poison,
dose
right?
that matters.
This is the poison. So
some will say that.
Right. The argument from technique. Sorry, I need to just my finish. And then, and there's no reason why we couldn't, if society decided that people with certain illnesses should be allowed to kill themselves more easily, to give them access to dispensing machines, that would give, because there's no medical technique involved in physician-assisted suicide. So it's really, it's an attempt to involve the medical profession,
right,
deliberately, to make what you said, this existential problem, a medical problem, and to make it more acceptable, and therefore to allow it to disseminate more.
Partially.
Allow us to endorse and give it a character that is more benign. Or less problematic than its usual existential character.
To medicalize the issue. Yes, right.
But you would say, we've talked a lot about, and Michelle, you particularly speak a lot about the relationship with the patient and how important that is. And it seems like, Tom, you're saying that there's somebody has to do this, and it shouldn't be. This is a problem. It exists. It needs to be dealt with, but it shouldn't be physicians. Don't you think that if you've been taking care of a patient, you have a wonderful relationship over the course of their lifetime, and is it somehow it somehow feels like abandonment during the end times to say, well, this isn't my problem. I know you're suffering. I know you're in horrible pain every day.
Right.
But, we're going to let, yes, I know I could make your suffering easier. You have no quality of life. You've been lying in bed and you can't get to the bathroom.
Right.
There's no dignity in the way you're living right now. And the patient is saying, please help me.
Yes.
Who should do that if it's not us? And why isn't that, Michelle, abandoning the physician? Why is it not abandoning this relationship?
I'll let Tom answer, and then if I have anything to add, I can add. But yeah.
So I don't. My argument was I'm not, by saying that physicians should not be doing it, I'm not thereby saying that we should that others should be doing it. I just want to be clear that physicians should not be doing it. That's really what my principal point is now, with respect to abandonment and Anish, that I think that's a very apt thing to be concerned about. You would know better than I because you are a physician and I am not. But from the one physician who with whose work I'm familiar on this is Ira Byock, and he has a wonderful book called. He was a former president of the American Hospice Association, and now he's a hospice physician in Southern California. And he has a wonderful book called Dying Well, Prospects for Growth at the End of Life. And what he commits to with his patients, he says, I'm not going to be involved in deliberately killing you. I'm not going to give you a deadly drug at your request. But I do promise you to accompany you along the way to your death, and that I will ensure that your pain and your symptoms will be bearable. That's the commitment that he makes to his patients. So he regards that as his commitment not to abandon his patients, while also not becoming involved in giving a deadly drug. He, in his experience, and he's been involved in the deaths of, being a hospice physician, of course, that's his practice. So he's been involved in the deaths of thousands of patients. And he has lovely vignettes that he's very moving stories about individuals whom he's accompanied, and he's kept that pledge to them. And he witnesses this growth that he says this growth, this process at the end of our lives, he thinks is our last opportunity to grow as we die. I know it sounds paradoxical and kind of counterintuitive, but he says we see people forgive one another. We see people being forgiven, asking for forgiveness, expressing their love, expressing their gratitude, and then finally saying goodbye. And in his judgment, which I'm relying on because, again, I'm not a physician, in his judgment and experience, that process, when it is completed, there is a growth, and there is a consolation for the individual as well as who dies, as well as for the loved ones. So that would be I hope that's somewhat helpful to answer that.
Yeah,
question.
no, I think it's a very good book, and I'll link to it on the show notes as well. There's one thing that you said, Anish, where you said, the patient may be just not only suffering, but they lose control of their bladder, their hygiene, and there's no dignity in that. Really, when we say there's no dignity in that, it's the patient may say it, but we reinforce that to them when we say that. And the truth is, there is dignity in being a human being, no matter what your condition. And so the moment we start qualifying what the dignity of human being is by saying, well, if you don't have control of your bowel and bladder, then you're really there's no dignity in that. I think that's false. I think that's false. And on the contrary, we should reassure them that, despite the calamity that the disease is causing, they retain their dignity, and it's very important. And what's not dignifying is being ill. I mean, what lacks dignity is the illness, which is the enemy, and we should always be on the side of fighting the enemy, as opposed to assisting suicide, which is really helping the enemy. We're just doing the job that the illness is taking a long time to do, and we're switching sides. It's a little switcheroo here that we're doing.
But it seems paradoxical, though. We talk a lot about allowing, giving physicians the ability to make decisions based on the individual circumstances, correct?
Mm-hmm.
But then it seems like when we get to this point, when patients may get to this point where they're asking, and patients ask all sorts of things. Patients ask for therapies. We frequently, and our job is not to just agree to what the patient says. Our job is to do what we think is best for the patient. Why not leave that decision? Why not leave that decision at the end of life between the patient and the physician? Meaning, is it? So, for instance, we have pacemakers. We have defibrillators, and these defibrillators will shock patients if they go into abnormal rhythms, correct? That's probably the easier one.
Mm-hmm.
And if it's frequently done where towards the end of life we will turn off the defibrillator so it will no longer shock the patient.
Mm-hmm.
That's a decision that's made between patient and physician.
Yes.
What is, I guess I have trouble because I'm constantly arguing about physician autonomy and allowing physicians to do what's best for the individual patient.
Right.
But if patient and physician come to the conclusion that the best thing to do is to turn off the defibrillator, is that a bad thing? If the patient and physician come to a decision that I have a pacemaker that is pacing my heart and that's the only thing that is keeping me alive, and because I cannot deal with my current state, and again, it's up to the physician to make that decision, right? The physician who's had a long-standing relationship with the patient. So this will prevent some physician some 40-year-old who's in a depressed state saying, hey, I want to die, and the physician saying, okay, here you go. No, that's not what I'm saying. I'm saying that why not leave that decision making between patient and physician?
With respect to that particular issue, certainly. So I would say with that specific issue of the pacemaker, and then more generally,
mm-hmm.
that's a therapeutic intervention. It's a therapeutic intervention. It is therapeutic, and so the decision is being made to stop that therapeutic intervention, and that's a therapeutic decision. So to employ a therapeutic intervention, or not to employ a therapeutic intervention, and to stop employing a therapeutic intervention, those are all therapeutic decisions. And I'm a huge, in my book, I've argued extensively for professional autonomy, definitely, and that physicians have professional autonomy as therapists, as caregivers. My quarrel with the deadly drug is that it's not therapeutic, and I can understand how people can view it as therapeutic, but I actually want to argue
mm-hmm.
that it's not therapeutic for the reasons I enunciated earlier. That it is no longer health is no longer being maintained or established in the individual patient, and we're actually getting rid of the patient, because the patient is that organic unity that is destroyed by the deadly drug. So that's my attempt, and I know that isn't always the most convincing kind of proposal, but I do think, though, that it isn't outrageous to say that death is not therapeutic, even for people who are in a grim state at the end of life, and there are conditions that are very challenging.
So actually, I disagree with you, Tom, on this point.
Okay.
So let's be clear here that, and let's use the easiest example. And I wrote about it. Perhaps I'll link to this. You have somebody who's got a pacemaker on, and it's an implanted pacemaker, and they're completely dependent on it.
Mm-hmm.
And what Anish is saying is that, how about we just turn it off? They're depending on this pacemaker that's been implanted. How about we turn it off? And you're saying this is a therapeutic decision.
Yes, I do think so, because it is a therapy that we're speaking about. So that this pacemaker was implanted for therapeutic purposes.
Yeah, I know. I disagree with that. I disagree with that position. I know it's been made. You're making it. It's been made by other bioethicists, but I think it's wrong. I think the pacemaker actually at that point is a part of the patient, and it's no longer a therapy to turn it off. It's actually, even though it is artificial, the fact that it's artificial doesn't change the fact that it's actually now part of the individual, right? And for example, if you have an artificial knee, the fact that it's artificial doesn't mean I cannot just come in and take it out and say, listen, it's not part of you. It's just it's not part of you. No, it is completely part of you. So same thing with the pacemaker. The pacemaker at that point is part of the person, and therefore it's a wound, to use your term, to turn it off. it's akin to coming and wounding the patient to turning off the pacemaker. The defibrillator case is a little bit more challenging, and I think it requires its caveat. The defibrillator would be a situation where you have a device that monitors your heart in case you have a cardiac arrest and it delivers a shock. Mm-hmm. And I think there one could make a case to change its defibrillating function, to reprogram it so that it doesn't do that. But for the pacemaker, I think it would be actually a wound. And I wrote that piece. I can't remember exactly all the arguments that I went through, but I went through all the arguments to show that it's actually the fact that it's artificial doesn't change the fact that it's really a part of the person. Mm-hmm. At that point. And there's a distinction between that and the situation of the patient being connected to a ventilator, mm-hmm. and why it's actually okay in that situation to disconnect the ventilator. There's a distinction. I mean, I don't want to get into it and sort of monopolize the conversation. Mm-hmm. But it's an interesting point and worth exploring more, and that's why I think all these conversations are so important about really what the role of the physician is. And another thing you could say is that, well, that's fine. I'm no longer acting as a physician. Now I'm going to act as X, and using my capacity as X, no longer my capacity as physician. I'm going to do
right, and
step X, Y, and Z.
At least that's going on record.
Right, correct.
One of the things I note in the book is that medical promising has enjoyed a renaissance, a rebirth in the United States with the white coat ceremony dating back to Columbia University's medical school in 1993. But many promises are taken at the white coat ceremony. That is, physicians, when they matriculate to medical school, they'll often, when they receive the white coat, they'll also make a promise or a profession or oath. But there may be many oaths that people take. It's no longer monolithic.
Right.
We live in a pluralistic.
Which in a way it's fine. It's a little bit more honest in a way. I mean,
right.
People can choose or declare exactly what they stand for, what they believe in,
and then patients can respond to that and choose physicians in light of their shared commitments.
Right, that's exactly right, and that brings a point to my mind, which I think goes along with what you write in the book, is that, and I talk quite a bit about it, is that licensing, the state licensing of physician, in a way, took that away from what was pre-existing before that, because before state licensing, you did have these different schools of thought about what medicine was about. Mm-hmm. So you have what we now call ourselves allopath, but it came from that Hippocratic tradition for the most part, okay? Mm-hmm. And it wasn't really exemplifying the Hippocratic precepts very well, but in the 19th century. But nevertheless, it came from that tradition. You had the homeopath that had their own thoughts about what health is and what the role of the doctor should be and so forth. And you had a variety of different people that had different conceptions.
Yes. And
patients could sort of choose
amongst,
and that was made explicit. Then now you have the government, the state, saying, no, medical care is essentially technical proficiency, because that's what you get your license on. Mm-hmm. You don't get your license on making a profession of anything. Mm-hmm. You get your license on your technical proficiency. And then it flips, so that the technical proficiency becomes the dominant aspect of what doctors do. Mm-hmm. And then that technical proficiency can be used for whatever purposes society deems appropriate, right? You can use it to do this and, X, Y, and Z. Mm-hmm. And so to me, there's a real damage in having, government licensing. It takes away, or maybe we don't have to get rid of it, but I think it's a step in the right direction, as you say, to have medical schools. Right now I think they do it as primarily a kind of a dog and pony. I mean, I don't want to say that, but I don't know that it has any sort of real.
The physician, I think it was Herbert Gould. He just passed away about 6 months ago. He was the physician at Columbia University Medical School. He who reintroduced the white coat ceremony and the taking the oath. And it's spread now. I believe it's almost every, if not every, medical school in the
right. But let's say
but he wanted to recover the humanistic tradition of medicine. Right. That was the
But let's say you break your oath. What happens? You're 5 years in practice, and you break the oath, whatever oath it was that you made. There's no consequence, right?
Well,
you're not going to be ostracized from that particular community of
Well, it depends on what you hold sacred, right? Because what's interesting about the Hippocratic Oath is uh, the Greeks took oaths. They were oath-taking people, the ancient Greeks. But the Hippocratic Oath is one of the few oaths that we know of that in existence that said, I swear by, he swore by Apollo and Asclepius and Hygeia and Panacea. And then he said, I swear by all the gods and all the goddesses, all the gods and goddesses. So it's a very solemn oath. Today it would be, I swear by all that I hold sacred. So the question is, what does one hold sacred? We don't necessarily, the Greeks weren't necessarily relying on the political authorities to punish the physician. They were relying on the divine, the gods.
Yeah, but at the end of the oath, they say, if I don't, I forgot what the phrase is, but at the end of the oath,
yes,
there are consequences. He will say, I will lose, I can lose everything.
Correct.
Right? If I don't.
In Greek oaths, it's interesting. It's different from our oath taking. In the Greek oath, there was always a blessing, but also a self curse in the oath. It was part of the oath. So it'd be like as if we were to say, if I commit perjury, I hope that I am imprisoned. We don't say that. We just say we don't speak about the punishment that we ought to receive if we break a promise that we make in a legal promise. But the Greeks, they spoke about, they actually enunciated the punishment that they would receive. So we don't necessarily have to rely on the political authorities of the person if the person really does have things that
I agree, because at the end of the day, even if we rely on the political authority, they issue licenses. Okay, so what? Have medical errors disappeared? Have bad doctors, have they disappeared? In fact, they've multiplied, if anything. Mm-hmm. Right? And the course, can we rely on the course, the malpractice course? I mean, there's a lot of injustice being, so at the end of the day, really, it's going to be the integrity of the physician, mm-hmm. right? And the more solemn physicians can be and can be made to be publicly, the better off the patients are going to be. And then if they can be explicit, as you said, by taking an oath, and you may have different oaths because, people have different values. If they can be explicit but solemn, and then held accountable by the community the community that believes in that oath, particular oath, then that's really the way to go, because otherwise, and especially because we are both healer and wounders, and it's very hard for, to come up with objective, determination that yes, there was malpractice or intent or whatnot, or all this is.
Well, even as you were just speaking about the pacemaker,
right,
and the defibrillator, and then the ventilator, you were drawing distinctions, and of course there will be those specific. There are cases of conscience, casuistry, deal with these differences, and there could be schools of thought concerning those. And it would be helpful to know as a patient, as a physician,
absolutely,
what are people's commitments.
Right. Absolutely.
It's a fantastic discussion, but I think that the disagreement will be, there are many contentious parts of this debate, but we talk about, the question is, what is health and what that means? When we're talking about what we all as a profession are committing to or giving an oath to, and you talk about healing and promoting health, I think that some of the disagreement among the various parties is
definitely,
what does it mean to, what does health mean? And to many people, it means relieving suffering. And once you get to, once you make that little leap, which is a long, a big leap that has all sorts of obstacles in it. I think you get into this area that's very contentious, because if the goal is relieving suffering, then all of a sudden there's lots of different things that are on the table. So
right, yes. You're right. But really, health. Health cannot be reduced to the absence of suffering, right? We all know that. We exercise, and when we exercise, we no pain, no gain, right? So we know that really you can't reduce health to the absence of suffering. But you're right. It's an important component, and I'm not saying I don't want to reduce suffering. It's a large part of what we do. But you're absolutely right. It needs, it's sort of the central issue. How do we articulate really what we believe in? So
so that's why giving autonomy to physicians to allow themselves to come up every patient-physician relationship is going to have its own definition of relieving suffering.
Mm-hmm.
And I'm somewhat comfortable with, if we have if we have an ethical folks and we try to promote an ethical group of a physician body, I'm then comfortable with leaving this to the physician and the patient. But
in a sense, I would agree with you but provided it's sort of made clear, that the physician can make clear ahead of time, what his conception of health is. And right now we live in times of ambiguity. I mean, it's been for a long time, but let's say the last 100 years, I mean, the concept of health is completely ambiguous right now.
Right.
And it allows all kinds of, perhaps mischief to happen.
Right.
And it allows, people and the public authorities to involve themselves and to influence.
Yeah.
So
yeah. No, and that's why this discussion is so important. There's that. I mean, I think it's happening all the time right now, Michelle. You could go through many cases of patients. Patients who are sitting in nursing homes who have been written off by multiple folks. Again, and I think the core thing in all these cases that I see is that there's no relationship that this person has with a healer, with a physician.
Right.
So whether it be the Canadian disabled person who is kind of being forced by the caseworkers to say, no, it's better that you just go along with euthanization, right? Now that poor person does not have a physician advocate who is there to kind of guard against this kind of mischief, as you're saying. The person you told me about, the 90-year-old who's kind of written off, who's sitting in heart failure, that is just not being treated because the health system. For the health system, it's better that, or for the system, it's better that this patient be on a morphine drip and die in 3-4 days. And so, it's
you're right, because you're absolutely right. Again, we've made it, and you're absolutely. I think the relationship is much more essential to what medicine is about than the actual technique. In fact, modern medicine has made the technique almost irrelevant, because you can teach a monkey to do an angioplasty, that sort of thing. So doctors is primarily about relationship and making decisions, not so much the technique, but making decision. But the decision is always, when you make a decision, it's in order to do something. So the end goal is what distinguishes one doctor from another, or one doctor's view of health from another. Because when you make a decision, it's in order to move in a certain direction, and what that direction is what is currently very ambiguous and problematic.
Right.
Wow, what a great discussion, Tom.
Well,
I think we're going to wrap it up here. There's a lot more in your book. You really, you touched on. I mean, there's a lot of history, very important history about who is even Hippocrates. How much do we know about it? I think that's fascinating.
Oh, thank you.
I think people will enjoy it. So I want to encourage everybody to get your book.
Thank you.
And you this is not to, you've written about other things that are important. You wrote a book. I mentioned it about the double effect reasoning, and I perhaps we can have you back on at some point to talk about this, because it's really essential to the kinds of decisions that we make every day in medicine.
Well, thank you
very much.
It's been a real pleasure. Thank both Anish. Thank you very much, and Michelle. Thank you.
Yeah, thanks, guys.
All right.
Bye bye.
Bye bye.